In the next few minutes, I'll talk about topical study design for atopic dermatitis, specifically to establish proof of concept, early designs. So I see in the room that there's a mix of people from the industry and practicing dermatologists. So my goal is for people from industry to show you various possibilities, some possibilities or some designs you may not be aware of. You may be aware of all the designs, so I'll try to highlight the pros and cons of the various designs so that you would be in a better position to choose the one that is more appropriate to your drug. For the practicing dermatologists, I want specifically to emphasize the limitation of some of those designs so that when you read publications, specifically early trials, you read it in such a way that you'll be able to identify which designs might overemphasize efficacy or overemphasize safety. So these are my conflicts of interest. I won't be talking about one specific drug, but I'll be showing you examples of various trials we've been involved in. So I'll mention drugs every once in a while. I'm also a shareholder of Innovative Research who has managed some of those studies. So as I said before, I'll briefly talk about phase 2B and 3 studies, briefly because these are usually more limited by the regulators. Most of the presentation will be around phase 1 and 2A proof of concept studies. I'll talk about placebo as well. So, as I mentioned, phase 2B and 3 are usually more dictated by the regulators, and these are different depending on the environment where the company wants to have approval. In the US, usually after a successful phase 2, a pharma company will request an end of phase 2 meeting with the FDA, will submit a plan for phase 3, and knowing what the FDA wants, the company usually aligns the study so that it would get eventually reviewed by FDA with a possible approval. What this usually means is that phase 2 and sometimes 2B and sometimes 3 are very similar from one molecule to another. There's always a comparator, which is usually a vehicle. In some localizations, in some areas around the world, you need to do a comparative trial with another agent in order to be able to justify a higher price. One thing you need to know is that any drug that is approved to be used chronically needs to be studied in at least 300 patients treated for 6 months and 100 treated for 1 year. So somebody we would like to put to market a drug with a 4-week treatment period only would not be accepted. You need to show safety and efficacy data for at least 1 year. So phase 3 trials, what they look like, typically 2 pivotal trials, hundreds of patients, usually more than 500, randomized 1-to-1, active versus vehicle. Sometimes you see designs with 2 different concentrations. Primary endpoint is usually IGA 0/1 and a 2-grade decrease. This is what the regulators want, specifically FDA. Primary endpoint in atopic dermatitis is usually between week 4 to week 8. And this is based on the fact that some of the drugs take some time to achieve good efficacy. So week 2 would probably be too early for many drugs. Week 12 or week 16 could show higher efficacy. However, from an ethical point of view and from a patient being in a study and staying in a study for a specific period of time, it would be more difficult. 12 weeks or 16 weeks without treatment would be more difficult. And there's usually an open label extension to get that data in 100 and 300 patients. These are sometimes offered for every patient. Sometimes it's offered for a limited number of patients, and I've seen companies as well, and I don't like this, when they open it to patients, and then once they reach a number of patients that is required by regulator to be able to submit the file, they just stop the trial, and I don't think that's the best way to go. Good. So now phase 1 and 2A, proof of concept study design. One question that I often get is, do we need in drug development for atopic dermatitis to use the drug in a first-in-man study in healthy volunteers. So in drug development with systemic drugs, this is almost always the case. There are exceptions like oncology, but in atopic dermatitis, a typical biologic or oral drug would have a single ascending dose, multiple ascending dose study in healthy volunteers. So should we do this or no in patients with atopic dermatitis? I personally think it's a good way to go. Patients with atopic dermatitis, as you know, tend to have more sensitive skin. So I think it's good to first try a new chemical entity in a new vehicle on normal skin to see if it's well tolerated. Sometimes I've seen pushback from either ethics or reg authorities if this is not done. It's also a good thing if the preclinical toxicity suggested issues. So sometimes you have drugs where the preclinical tox on mini pig skin, for example, suggests that it induces irritant contact dermatitis. I think it's safer to try on normal skin. The main advantage I see is you can document that it's well tolerated or not on normal skin. So you would, if you have a small cohort of healthy volunteers, we would be able to see if it does burn or not on normal people, normal skin. Disadvantages, slightly more costly for drug development, delays of a few weeks. Obviously, it doesn't guarantee that if it's well tolerated on normal skin, that it will be tolerated on atopic dermatitis skin. So what I suggest as a strategy is not to conduct a specific study in healthy volunteers, but to add a small cohort of healthy volunteers in first-in-man studies in atopic dermatitis, treated for a week or two, drug application at the clinical site, treatment of the face as well, so that this data is generated. So how to best establish proof of concept? I'll first talk about the intra-patient design. This is something very powerful that can be done when you have a topical drug that you study for atopic dermatitis. It cannot be done, obviously, with a systemic drug. The intra-design or intra-patient design uses the fact that patients with atopic dermatitis will have lesions on many areas, and you can treat one area with the drug that is being studied and another area with a comparator or a vehicle. There are some risks associated with that, specifically if you send your patients home with tube A to be applied on the right leg and tube B to be applied on the left leg. Patients often don't do what we tell them to do, and I'll show you examples, so I don't think that's the way to go. If you choose that design and the applications are done on site, it's much better. However, it requires a longer time to recruit patients. So I'll show you an example of what I just mentioned. This is a psoriasis trial in which we participated with Pfizer, topical tofacitinib in psoriasis that we did a few years ago. And the way the trial was conducted was patients, 81 patients total, were recruited with at least 2 areas involved with psoriasis, and they were given either tofacitinib at 0.02, 0.2, 2%, or vehicle. They were given 2 vials. Were sent home and were said apply vial A on plaque A and vial B on plaque B. So the primary endpoint was at week 4, and when we looked at the data at week 4, we didn't really see efficacy. There was no difference between vehicle and active treatment. However, there were biopsies in that study, and when the biopsies were analyzed, Pfizer found presence of drug on many patients on the vehicle side. Suggesting, what did they do? We don't know. Did they mix up A and B? Did they say, well, I want to get better, so what I'll do is I'll put it all over? Or even worse, were patients who would see a good improvement on lesion A try to say, oh, the A works, so I'll use it on the area B. We don't know. What was good is that in that study, there were also patients who were randomized to vehicle. So the data was reanalyzed, considering vehicle, patients who received only vehicle, and active, and this is what the results shown. So what you see here is you see that when you analyze the vehicle areas only in patients who had vehicles on both sides, you see that there is efficacy. So that type of design is the type of design that I don't suggest using. And just for the from an historical perspective, Dr. Gooderham will talk about tapinarof first, but what's not in the literature is that the first study conducted with tapinarof was conducted with that design, so that I tried to convince the company not to do it. They did it, and it was not so great in terms of efficacy, because when we got to a higher concentration, everybody was getting better everywhere. Another way of doing the intra-analyses is to have patients come to the site, and this is a study we conducted with Emma Gutman. We published a few years ago, 30 patients with atopic dermatitis, once-a-day application for 2 weeks on site, various topical corticosteroids, pimecrolimus in a vehicle, different endpoints. So this is an example of one patient where you would treat with clobetasol and you would see clearance or almost clearance in an area. So one of the advantages of those designs is that if you see clearance in a circular area where you apply the drug, you know you have efficacy. If you have one area, when you apply the drug on atopic dermatitis in the entire area, and then you see clearance after a month, this could be the drug, but it could also be just fluctuation of the disease. And you know now that there's no fluctuation. So what we found is clinical improvement. So we used an evaluation tool called TSS, and what we found is as early as 1 week, we could differentiate the vehicle, pimecrolimus, and the 2 steroids. It was the difference between the vehicle and the 2 steroids was statistically significant at 2 weeks. We also found the same difference in terms of transepidermal water loss, which was also significant, difference between vehicle and the 2 steroids at week 2. And on skin biopsies, we also looked at various biomarkers, and we found a decrease in IL-13, a decrease in IL-22. And when you look at the molecular signature, you can see that there's a big difference with the 2 steroids and some kind of a milder difference with pimecrolimus. Now, this type of intra-patient design, where the drug is applied on site, is very powerful, very sensitive, and you can even detect differences after only 2 applications of study product. This is a study that we did and presented at the late ISDS meeting in Vienna, a study we did in collaboration with Emma Gutman again. This was a study that was done to look at the mechanism of action of crisaborole on atopic dermatitis. So 40 patients with at least two areas involved with atopic dermatitis, randomized to have crisaborole on one area, to have vehicle on the other area, twice-a-day application for 2 weeks at the clinical site. And I'll show you data of pruritus. So this is pruritus according to time. So change from baseline in pruritus on the area treated with vehicle, the area treated with crisaborole. And you see that at day 2, which is 1 day after the start of the application, there was a statistically significant difference in pruritus between the 2 areas. So for physicians, when you have that type of intra-patient design, it's easier to detect differences because you can look at the 2 areas and you can compare. You shouldn't do that. You should evaluate area A and area B and do your evaluations, but you see both. For patients, it's the same. So it's probably much easier for patients to see a difference in pruritus when you compare your right arm to your left arm. And this study also shown that there was a statistically significant difference in IgG 0/1 with only 40 patients after 2 weeks of treatment. So what about the classic inter-patient randomization scheme? Is it good? Is it not good? Yes, it's good. That's how tapinarof was first shown to be efficacious in atopic dermatitis. So in this study, 37 patients were randomized to 2 concentrations of tapinarof versus vehicle. They were given the creams to put at home. So vehicle patients had only vehicle, and patients who received tapinarof had only tapinarof. And it was statistically significant, very easy to see. You see on those photos as well some improvement in patients who were randomized to 0.5 1%, and no improvement in patients randomized to placebo. So that's the classical way of doing things, which is fine. The advantage of doing it this way is that the results you get are results that are similar to what you should get in later phase studies. So a company doing drug development, if you use that route for phase 2A, you can use the data to power for a phase 2B study or a phase 3 study. Topical tofacitinib is another example, a study we conducted in 69 patients randomized to vehicle or active tofacitinib, very clear efficacy at week 4, very easy to see the difference. So the advantage of this, I think that if a company is developing a drug where the mechanism of action is known, it's a known drug to be efficacious in the disease, that's a good way to go because you get your data and then you can power for phase 2B and phase 3. If you have a new chemical entity, you don't know if it works in atopic dermatitis, you might be better off with an intra-patient design strategy where you optimize the conditions to see a difference. Now, what's the best primary endpoint in terms of efficacy? IgA 0/1 and a 2-grade decrease, as I mentioned, is what the regulators want. However, the bar is fairly high, not always easy to achieve in short-term development. That's one of the issues we often see in dermatology. Companies developing new drugs usually do talks for 4 weeks with a topical drug. And it's not always ideal to stop at 4 weeks. I like to push it a little bit, maybe to 6 or a little more. So it's more difficult to see the efficacy in if you choose IgA 0/1. However, it helps you for phase 3. Other possibilities are change from baseline and EASI, and we see this fairly often. I try to like it, kind of like it from a statistical perspective. However, it's more difficult to imagine what does that mean. So if I see a patient, if you tell me as a clinician that a drug will get half of my patients clear, almost clear, in my mind I have a picture. If I'm told that a drug will give on average a decrease in EASI of 45%, I don't have a clear picture. So that might be good to get a primary endpoint where we achieve efficacy, we can say statistically significant and publish, but the regulators won't accept this in later phase studies. Now, study design and safety for topical drugs. So there are 2 types of issues you can run into with topical drugs in terms of safety. There are some local effects and some systemic effects. So systemic effects are rare with topical drugs. I'll talk a little bit about it. It's mostly the local effects that we see and we're concerned about. And in my experience, it's usually an atopic dermatitis, burning and stinging, irritant contact dermatitis, allergic contact dermatitis, xerosis sometimes. Unfortunately, some drugs are not soluble in ointments or creams where the lipid phase is high, and some companies have to formulate it more in a gel form. Aqueous gel is not always ideal for atopic dermatitis or worsening of atopic dermatitis. So it's a little strange because I'm copying my presentation. There's a color that changed, but that's not important. So I want to tell you that with the proof of concept study, with a small number of patients, you're usually good to detect a drug that would induce irritant contact dermatitis or burning sensation or xerosis in a high number of patients. However, if it's allergic contact dermatitis you're interested in, this is not good. You need to treat hundreds of patients, obviously, to detect that. Now, just a few words on systemic effects. So systemic effects with topical drugs are possible. One thing I didn't mention when I talked about phase 3 is I mentioned the 2 typical pivotal trials that a company needs to do in order to get approval, but that wouldn't be enough to get approval. So if a company has a topical drug that they want approved in atopic dermatitis, in addition to that, they need to do a maximum use study, which usually requires recruiting patients with 25% body surface area and more covered with atopic dermatitis, where you apply the cream all over, you do PK, you do safety, Companies have to do additional studies, including an irritation, 21-day irritation study, a sensitization study in more than 200 patients. If the drug absorbs in UV, they need to do photoirritation, photosensitization study. And obviously, because this is atopic dermatitis, by the time the drug is approved, there are usually pediatric patients exposed, and companies have to go down to a very, very young age in order to eventually get the approval, or they have to commit to do that after approval. So this is a study we conducted with tapinarof, double the concentration that is currently in phase 3. So this is tapinarof 2%. It was a maximum use study in patients with 15% BSA or more. And we were fairly surprised when we got the results of that study because a number of patients had nausea, vomiting, and diarrhea. And the tolerance of that 2% in atopic dermatitis was not good. There were systemic effects, and headache was number one. And Melinda will talk about we'll talk a little more about tapinarof later on. So burning and stinging sensation. So one of the limitations of those studies conducted, intra-patient study conducted in a limited number of patients, is it's not always easy to study burning and stinging on small areas. So if you, for example, put 3 or 4 areas on a forearm and you ask patients, oh, you have stinging, which area is really stinging? It's tough for patients to differentiate. So that's one of the limiting factor. One thing you need to keep in mind as well is often the proof of concept studies, they exclude sensitive areas. So it's not rare that a first-in-man study in atopic dermatitis would exclude application of the drug on the face, the folds, and the genitals. So these are the sensitive areas. Even if it's allowed, when you read the literature and when you prepare for a later phase study, you need to be aware, if you're not a clinician, that adult patients with atopic dermatitis don't tend to have that much atopic dermatitis on the face. They tend to have it on the limbs. So a 30-patient first-in-man study in atopic dermatitis, even if the product could have been applied on the face, sometimes you may have just a few patients with facial atopic dermatitis. When you go down in age and you include children in later phase study, they tend to have much more AD on the face, and you might have a different type of safety profile observed. Good. So one of the things, something else I want to bring your attention to is that you need to be aware or careful when you conduct those studies. If you have a dose ascending strategy where you increase your dose by increasing the amount of product you apply on the skin. So I've seen companies do studies where they start by at 2 milligrams per square centimeter, and then 4, and then 10, and then 20, and then more. In practice, patients don't use that amount, and you can get into trouble because of the vehicle. And I've seen this in one study where we had contact urticaria when we first applied the product at 20 milligrams per square centimeter, and it was not the drug. It was something in the vehicle that created this type of reaction. For clinical dermatologists, those intra-patient type of design, they tend to overemphasize efficacy. So beware, because it's a perfect type of treatment adherence. Patients come in, they don't miss a dose. The cream or the product is measured every time. They're instructed not to take a bath or shower. So there's usually if it shows efficacy, the efficacy that you would observe later could be lower. So tools to measure efficacy, and I'll be closing with that. So when you measure efficacy in those proof of concept studies, looking at the areas where the product is applied, you have a few options. One options are the classical tolerance scales that are used in dermatology, where you evaluate erythema, scaling, pruritus, edema. These are not ideal for atopic dermatitis because the typical lesion of atopic dermatitis is pruritic with scales and erythema. I don't like that personally. Another option is to do a systematic evaluation of tolerance at every visit by the dermatologist, and if there's an issue, this is entered into an adverse event. A third option, which I don't like either, is just to say nothing and expect that the patient would report any type of adverse event. So last slide on placebo, just to let you know, those of you who do IIS studies, investigator-initiated studies, sometimes academic institutions don't like the fact that we're using placebo in atopic dermatitis, specifically in infants and children. This is, as you know, something that is done routinely. Vehicles are not placebos. The effect of topical moisturizers is always very high, decrease of TEWL, moisturizing property, effect on antibacterial effects sometimes as well. There's an interesting position paper that has been published by IEC recently on the use of placebo in atopic dermatitis, and you can try to refer to that if you need to convince your ethics boards that it is sound to use a vehicle as a placebo in patients with atopic dermatitis. Thank you.